Ever find yourself looking at a complex medical picture? Maybe something that looks, well, exactly like an epileptic seizure, but there's this nagging feeling like one piece just doesn't quite fit.
Hmm.
Or maybe you're grinding through revision trying to get a handle on conditions with these really confusing, overlapping symptoms.
Yeah, the challenge of telling similar things apart, especially, in clinical presentations, it's huge. It's exactly the territory we're exploring today.
Absolutely. And it's a common scenario, isn't it? The body, well, it has a limited range of symptoms, and totally different causes can look remarkably similar on the surface.
Right. Being able to spot those subtle differences, particularly when you're under pressure or, like you said, studying for exams, that's invaluable.
Definitely. And that brings us straight to our topic, psychogenic non-epileptic seizures, or PNES. We're going to do a deep dive today based on some revision notes one of you actually shared with us.
That's right. So the mission today is to take this stack of focused revision notes and really unpack them. We'll pull out the most crucial, sort of high-yield information.
Helping you convert what might feel like dense text into a clearer, navigable mental map for understanding PNES quickly and, well, thoroughly.
Exactly. We're essentially using these notes as our guide, drilling down into what's most important.
Think of it as maybe shortcutting your way to being well-informed on this specific topic, straight from material design for focused learning. Okay, let's kick things off right at the start. What is PNES? The core definition in these notes seems key.
It really is. The notes are very clear. These are episodes that, look strikingly like epileptic seizures. You might see shaking, sometimes unresponsiveness, those quite dramatic physical signs.
But the fundamental difference, the absolute core concept, is that they are not caused by that abnormal electrical activity in the brain that defines epilepsy.
Exactly. And the source material makes an important link here. It connects PNES to the concept of conversion disorder.
Ah,
This is where significant psychological distress or conflict doesn't get expressed emotionally in the usual way, but instead gets sort of converted or manifest as physical symptoms, like these seizure-like episodes.
so it's a physical symptom, but its origin is psychological. And the notes stress this crucial point. These episodes are involuntary.
Hmm.
This isn't someone consciously faking it or malingering. The person genuinely experiences these symptoms, even though the cause isn't neurological in the same way epileptic seizures are.
Precisely. And they're very strongly linked to emotional factors, things like a history of trauma, maybe ongoing stress, or underlying psychiatric conditions. The notes also mention a synonym you might come across, particularly in the UK, non-epileptic attack disorder, or NEAD.
NEAD. Okay, good to have that alternative term. And a definite instruction from this revision material. Avoid that outdated and really stigmatizing term, hysterical seizures.
Oh, absolutely. It's medically inaccurate and, frankly, carries a terrible history of dismissing genuine suffering. Now, interestingly, right here in the definition section, the notes immediately start listing points that help differentiate PNES from true epilepsy.
Right.
And this is where it gets really interesting, because they show just how much overlap there can be, making diagnosis quite tricky.
Totally. They list factors that might favor PNES, things like pelvic thrusting during the episode, which isn't a typical epileptic movement,
Right.
or maybe counterintuitively a family history of epilepsy, which makes you think maybe about the environment or shared experiences.
Yeah, that family history point is fascinating, isn't it? Why would having family members with epilepsy make you more likely to have non-epileptic seizures? The notes don't spell out the why, but it immediately makes you consider things like, observational learning, or maybe shared stress related to illness in the family.
Interesting. What else?
Other points favoring PNES mentioned are it being more common in females crying after the episode, the fact they often don't happen when the person is alone,
That's different from many epileptic seizures, yeah.
and a gradual onset rather than the sudden collapse you sometimes see in epilepsy.
Right, gradual onset versus sudden. And then they list features suggesting true epileptic seizures, things like tongue biting, specifically mentioning the side of the tongue, which is a classic sign, and raised serum prolactin levels measured after the event.
But the notes quickly circle back to the difficulty. They state explicitly that some overlap exists. Both PNES and epileptic seizures can cause loss of awareness, potential for injury during the episode, and sometimes even incontinence.
So seeing just one of these features isn't enough. You need the whole clinical picture and, well, often further tests.
Exactly.
Okay, so we know what it is, and some initial clues about what it isn't. Moving beyond the what, the notes delve into the why, the etiology, the causes and origins, and the risk factors. So what actually causes PNES?
Well, the source material describes it as complex and multifactorial, but the overwhelming emphasis is on psychological factors, significant emotional distress, a history of trauma, things like abuse or PTSD, and coexisting psychiatric conditions like anxiety, depression, or personality disorders are really highlighted.
It really drives home that mechanism we mentioned. It's the conversion of that psychological distress into physical symptoms.
Yes, the notes describe it as an interplay of psychological factors, how a person processes emotions, and their individual cognitive or maybe emotional vulnerabilities.
And again, that surprising point comes up. A previous diagnosis of epilepsy or another neurological condition is listed as a risk factor for developing PNES.
Yeah, think about the potential stress and life changes that come with a neurological diagnosis. It's sort of easy to see how that could contribute to psychological vulnerability, right?
That's a critical piece of insight for clinicians to remember. Don't just assume all spells in someone with epilepsy are necessarily epileptic. What are the other major risk factors listed in the notes?
The notes are pretty comprehensive here. A clear history of psychological trauma or abuse is prominent. The presence of psychiatric disorders, anxiety, and depression are very common comorbidities.
Okay.
Unresolved emotional conflicts, high levels of stress, or ongoing life difficulties. And as we said, it's more common in women, although it affects all ages and demographics.
And they specifically call out certain conditions.
Yeah, comorbid conditions like borderline personality disorder or dissociative disorders are mentioned as significantly increasing the risk.
Right. Let's get deeper into the pathophysiology. How exactly does this conversion from distress to physical symptom happen in the brain?
Well, the notes acknowledge that this is an area still needing more research, but they state it's understood to involve the brain's response to emotional stressors.
Okay.
These stressors are thought to sort of alter neural networks, leading to the generation of these seizure-like episodes.
So it's not a structural problem or an electrical misfire like in epilepsy, but something about how the brain is processing intense emotional input and maybe translating it into a physical output.
Precisely. It circles back to that interplay. It's the psychological factors interacting with emotional processing and those pre-existing cognitive or emotional vulnerabilities that seem to prime the brain for this type of functional neurological symptom.
But, like the notes say, the exact step-by-step mechanism isn't fully mapped out yet.
No, not fully. It's still an active area of research.
This raises a really important question. If it mimics epilepsy so closely, what else could it be? The differential diagnosis must be absolutely critical for getting the right treatment.
It is. PNES is listed as a primary consideration when someone presents with apparent seizures. Differentiating it from true epilepsy is highlighted as the key clinical challenge.
The notes then broaden the view, right, to include other medical causes of transient neurological dysfunction that could be mistaken for seizures.
Yeah, things like syncope, a simple fainting, or fainting caused by heart issues. Other neurological problems like a mini stroke or stroke, TIA, migraine with aura, or even vertigo.
And metabolic or endocrine issues, low blood sugar, hypoglycemia, or low calcium, for example.
And also effects of drugs or alcohol intoxication or withdrawal can sometimes look seizure-like.
Interesting. The notes also list other psychiatric conditions that can resemble epilepsy. Panic disorder, especially if there's hyperventilation leading to lightheadedness or even collapse, that can look quite traumatic.
Definitely. Psychosis is mentioned, and surprisingly, even some presentations of ADHD are listed in these notes.
Wow. That breadth of possibilities really underscores why a thorough history is so important.
Absolutely. The notes also mention other conditions like dissociative seizures, which are often functionally grouped with PNES, and importantly, factitious disorder, where symptoms are consciously faked.
But the notes make that crucial distinction again. PNES is involuntary, unlike factitious disorder.
Yes, that involuntary nature is absolutely key to understanding and managing PNES correctly. Given this complex list of possibilities, the notes strongly emphasize the need for collaborative evaluation.
Right. It's not just a job for the neurologist or just for the psychiatrist.
No, these cases require a team approach between neurology and mental health professionals to really sift through the possibilities and reach an accurate diagnosis.
And the notes reiterate that PNES can mimic both types of epileptic seizures, those big generalized clonic seizures, and also the more subtle focal seizures.
They mention video EEG monitoring here again as crucial for differentiation. A test we'll dive into more in the investigation section.
Okay.
And other conditions to just keep in the back of your mind for the differential include various movement disorders, certain sleep disorders, and other functional neurological disorders.
So who is typically diagnosed with PNES? Let's look at the epidemiology according to these notes.
Well, the exact prevalence is uncertain, largely because of that diagnostic challenge we just discussed. It's often underdiagnosed or misdiagnosed as epilepsy, sometimes for years.
But the estimates from the notes are pretty significant. It's thought to account for a considerable proportion of referrals to epilepsy clinics, somewhere between, 15% to 20%.
Yeah, around that mark. And if you look at long-term epilepsy monitoring units, where patients are admitted specifically to capture episodes on video EEG, PNES is diagnosed in an even higher percentage, sometimes between 10% and 40% of those patients.
Wow, up to 40%. That tells you how common it is among people thought to have difficult-to-treat seizures.
It does. It's commonly diagnosed in women, often presenting in early adulthood, but importantly, the notes state it occurs across all socioeconomic and ethnic groups.
And reinforcing the etiology, the notes link the epidemiology back to trigger factors, right? Noting that psychological stress exceeding a person's coping capacity often precedes PNES episodes.
Exactly. That link to stress is consistently highlighted.
Okay, let's get down to the nitty-gritty of what you might actually see. What does a PNES episode look like? The clinical features are where observation becomes absolutely critical.
Right. The notes emphasize that PNES can visually mimic epileptic seizures, presenting with loss of consciousness, convulsive movements, shaking, abnormal posturing, or unresponsiveness. But they list specific differentiating features, and these are gold for distinguishing it, especially when you're revising.
Let's go through the features that strongly suggest PNES directly from the notes. Look for episodes that are longer in duration than typical epileptic seizure.
Right, duration is a big one.
They often have a gradual onset, sort of building up rather than a sudden drop.
Yes, the duration and onset are key patterns to spot. The notes also mention a fluctuating course with waxing and waning intensity, unlike the more consistent progression of many epileptic seizures. You might see violent thrashing or quite bizarre movements that don't really fit typical seizure patterns.
Violent thrashing, or that side-to-side head movement rather than rhythmic head nodding. Also, asynchronous movements where different limbs are moving independently or in different ways, which is atypical for generalized epilepsy.
And a really classic high-yield differentiator from the notes.
Mm-hmm.
The eyes are often closed tightly during the episode, sometimes even resisting opening.
Ah, okay.
Whereas in true epileptic seizures, the eyes are often open. And fascinatingly, some individuals with PNES might report being able to recall events during what appeared outwardly to be a state of unresponsiveness.
Wow, recalling events during apparent unresponsiveness, that's a major clue to the nature of the episode, isn't it? Okay, what features from the notes suggest true epilepsy instead?
The notes list automatisms, those repetitive, semi-purposeful movements like lip smacking or fumbling with clothes.
Okay.
Urinary incontinence can occur in both, but is perhaps more typical of generalized clonic epileptic seizures. Again, specific mention of tongue biting, particularly on the side of the tongue, is a strong indicator of epilepsy.
That detail about the side of the tongue is a great memory hook. But despite these differentiating features, the notes give a vital reminder. It's challenging to distinguish.
Very challenging.
And critically, epilepsy and PNES can coexist in the same person. You can have both types of events.
Absolutely. That's crucial.
Both can cause loss of awareness, potential for injury, and sometimes incontinence. So you really cannot rely on just one or two features. A thorough assessment is paramount.
So how do we move from suspicion based on clinical features to a definitive diagnosis? The investigation section outlines the path.
Diagnosis requires a comprehensive approach. The notes highlight a detailed medical and psychiatric history as absolutely crucial, along with a physical exam. But the gold standard, the test that really clinches the diagnosis, is video EEG monitoring.
Right. Let's explain video EEG a bit more. It's a continuous recording of the brain's electrical activity using electrodes on the scalp, that's the EEG part, simultaneously recorded with a video camera capturing the patient's behavior. The patient is typically admitted to a special unit for several days, sometimes even longer, specifically to capture one of these episodes.
So if an episode occurs that looks seizure-like on the video, the doctors can look at the EEG recording at that exact same moment.
Exactly.
In true epilepsy, you'd expect to see abnormal electrical discharges on the EEG coinciding with the physical event. In PNES, the video shows the seizure-like behavior, but the EEG remains normal during the episode.
Precisely. That direct comparison of behavior and brain electrical activity makes video EEG the primary tool to definitively differentiate PNES from epileptic seizures.
And equally crucial, the notes emphasize, are psychological and psychiatric assessments. You need to delve into the patient's history of trauma, stress levels, and screen for those underlying emotional and psychological factors.
Which is why collaboration is so key. Neurologists need to involve psychiatrists and other mental health professionals in the assessment process.
Definitely. The notes also mention other investigations, but primarily to rule out other physical causes that might mimic seizures or to assess for comorbid conditions, standard EEG. But remember, a single EEG might be normal even in epilepsy, so it's not definitive for excluding it on its own. MRI brain scans to rule out structural causes of epilepsy or other lesions.
And blood tests to check for metabolic issues. Fasting glucose for blood sugar, electrolytes. Also cardiac tests like ECG and echocardiogram to rule out heart issues that could cause syncope mimicking seizures.
A vital takeaway from the notes, worth repeating, an EEG alone should not be used to exclude epilepsy if the clinical history and observations strongly suggest otherwise.
Right. Clinical judgment and observation, those features we discussed, are paramount alongside, ideally, video EEG.
And they bring up serum prolactin again here. What's the clarification?
The notes clarified that while it may rise after a generalized tonic-clonic seizure, it's not a reliable test for differentiating between epileptic and non-epileptic events.
Why?
Because it can rise in other situations too, like after syncope sometimes, and not all epileptic seizures cause a rise. So it's pretty non-specific.
Okay, so while it's in the notes as something to be aware of, don't lean too heavily on serum prolactin for differentiating PNES from epilepsy.
Exactly. And a final reminder from this section. Many patients do have both types of seizures, and PNES frequently coexist with mental health issues like anxiety, depression, and personality disorders, which just adds layers of complexity to diagnosis and, of course, management.
Right. So once a diagnosis of PNES is confirmed, what can actually be done? The management section in the notes outlines the approach.
It stresses that a multidisciplinary approach is essential. This isn't something a neurologist treats alone with anti-seizure medication. It requires combining neurological understanding with psychological interventions.
The focus of treatment is squarely on addressing those underlying emotional and psychological factors that are, well, driving the symptoms.
Right, and psychotherapy is highlighted as the key therapeutic intervention, particularly mentioning cognitive behavioral therapy, CBT.
CBT, how does that help?
Well, CBT helps patients identify the triggers for their episodes and then develop better coping strategies for dealing with stress and emotional distress.
Makes sense. What about medications?
Psychiatric medications may be used, but the notes clarify that these are primarily for treating any comorbid conditions like anxiety, depression, or personality disorders.
Oh, okay.
Not as a direct treatment for the PNES episodes themselves. Giving anti-epileptic drugs for PNES is inappropriate and potentially harmful.
Right, because they won't work and have side effects. And again, that collaboration between neurologists and mental health professionals is vital for ensuring the patient gets integrated care.
Absolutely. Addressing both the symptom and the underlying cause. Education and support are also critical parts of management, not just for the patient, but for their family as well, helping them understand the condition and how best to support the patient.
And the notes explicitly state that patients with suspected or confirmed NES should be referred to psychological or psychiatric services. It's not really an optional extra, is it?
No, it's fundamental to effective treatment. And a really important point highlighted is that there's no reliable evidence supporting specific drug treatments for NES itself, reinforcing that the treatment is psychological and psychiatric, plus addressing any comorbidities.
Okay, what about the future? The prognosis section covers the outlook for someone diagnosed with PNES.
The prognosis varies quite a bit. It depends on factors like the severity, the underlying psychological distress, whether other health conditions, those comorbidities are present, and how well the individual engages with and responds to treatment.
The good news, though, is that interventions, particularly psychotherapy, can significantly reduce seizure frequency and often improve the person's daily functioning and quality of life.
Yes, definitely. However, the notes also state that some people may continue to experience episodes even with treatment, meaning complete remission isn't guaranteed for everyone.
The long-term outlook is clearly influenced by factors like a history of significant trauma, ongoing life stressors, and the presence of those other psychiatric conditions.
But a clear point emphasized is that early diagnosis and getting into comprehensive multidisciplinary treatment significantly enhance the prognosis. The sooner the psychological factors are addressed, generally the better the outcome.
The notes also briefly mention the prognosis for organic non-epileptic seizures, those caused by other medical conditions like cardiac issues or metabolic problems.
Right, and for those, the prognosis depends entirely on successfully treating that underlying medical cause.
Makes sense. And the key factors from the notes specifically influencing a NES prognosis include the individual's psychiatric history and current state, the age and onset of the PNES, whether coexisting epilepsy is also present, their history of trauma, and crucially, the patient's willingness to accept the diagnosis and actively engage with psychological treatment.
Yeah, that patient buy-in is absolutely vital for success.
Finally, what are the potential downsides or things that can go wrong? The complications section.
Well, PNES can have a significant impact on a person's life. It can severely affect their quality of life and their ability to function independently day to day.
It can impair relationships, make activities like driving impossible, and impact employment and the ability to work.
And those comorbid psychiatric conditions we keep mentioning add layers of complexity to management and can certainly worsen the impact on quality of life.
And a major complication highlighted is the impact of delayed or misdiagnosis.
Huge. This can lead to years of ineffective treatment, potentially harmful exposure to unnecessary anti-epileptic drugs and their side effects, and continued disability because the root cause simply isn't being addressed.
Yeah, getting that diagnosis right and early is so important. The notes underscore that providing support, education, and ongoing care is essential to minimize these long-term complications and improve outcomes.
Definitely.
Wow. Okay. We've taken those revision notes and really worked through them, covering everything from the core definition, why it happens, what it looks like, how you figure it out with specific investigations like video EEG, how it's managed primarily through psychological approaches, what the future might hold, and the potential complications if it's not handled well.
Yeah, hopefully turning that density into a much clearer mental map.
That was the goal. The core message from these notes seems crystal clear. PNES is a genuine and often disabling condition originating from psychological distress, requiring careful, precise differentiation from epilepsy, and demanding a comprehensive, multidisciplinary treatment approach centered on psychological support.
Absolutely. Understanding these key points, spotting those differentiating features, knowing the diagnostic pathway and management principles, it's all crucial, whether you're studying for an exam or encountering this in clinical practice.
It really highlights that incredibly intricate link between our mental and physical health, doesn't it? How psychological experiences can profoundly shape physical symptoms.
It really does.
Absolutely. And if you found these notes helpful and are looking for more high-yield revision resources like this deep dive, be sure to check out PassThemSRA.com.
And remember, you can find free resources specifically designed for revision at freemasSRA.com.
So next time you see a presentation that looks like a seizure but doesn't quite fit the classic pattern, remember PNES. It leaves you wondering, how many other physical symptoms that baffle us might have hidden roots in the complex landscape of human psychological experience? Something to consider.